Hi, I'm Frank Diamond, the managing editor of Infection Control Today, where we're giving infection preventionists and others on the front lines battling COVID-19 the information they need to guide America through this pandemic. Masks, that's been a constant sore point throughout this crisis. Their supply or lack of supply. Who needs to wear them and when? And what kind? That brings me to my guest, Dr. Harry Peled. Dr. Peled is one of the authors of an opinion piece in the Annals of Internal Medicine that garnered a lot of notice last week. In that article, Dr. Peled and his co-authors wrote that, and this is a direct quote from his article, "We believe that a thoughtful evaluation of past and existing data in the setting of the COVID-19 pandemic strongly supports the use of N95 respirators for all inpatient care of patients with COVID-19, not only during aerosol generating procedures." Dr. Peled also wrote that, and this is another direct quote from the article, "A COVID-19 inpatient unit with multiple patients coughing and breathing will have a far higher exposure to droplets, suspended droplets, and aerosols than an outpatient setting. The data the guidelines reference do not support the conclusion that medical masks are equivalent to N95 respirators in reducing risk for infection." Dr. Peled is the medical director of cardiology and critical care at Providence St. Jude Medical Center in Fullerton, California. Doctor, thanks for being here today.
Thank you so much. Thank you so much.
So you just heard me quote from your article, and I want to ask, I guess my first question is, what made you decide to write it in the first place?
Great question. There was a lot of angst, as you said, going around this issue, and there was really a lot of moral distress and a lot of disunity going on. You had healthcare workers who said, I clearly need to have an N95. You had administration and supply chain people in good faith following the guidelines saying, you know what, that's not guideline based. I have to save these masks for the aerosol generating procedure. So you can't really have these N95s. And in the midst of a COVID crisis, you had a really horrible clash between the workers and the administration, everybody trying to do the right thing, but it was certainly a very poisoned atmosphere. And whenever people quote the guidelines, I think one of the most important thing is to go, what is behind the guidelines, right? At the end of the day, guideline writers, like all of us, try to do the best thing. There are a bunch of people sitting in a room, trying to put this together, especially in the setting of COVID. Everything was done pretty quickly. So I took the time to look at the articles which were supporting that face masks were equivalent. And I found that the evidence was just simply not there to say that they were equivalent. And it also was interesting that the data to support N95 for the AGPs, the aerosol generating procedures, was not very impressive either.
What kind of blowback have you gotten from that article? I mean, it was pretty, let me back up a little bit. Let me try to paraphrase what I think you said in the article. You tell me where I'm wrong, okay? What I read is that you think that anybody who is dealing with a patient in the hospital that has COVID-19 in that hospital should be wearing an N95 respirator. Where am I wrong?
No, that is correct. I think anybody who is on an inpatient side, you're taking direct care of a COVID patient, you should be having an N95.
And when you talk about the guidelines, are you talking about guidelines from the U.S. Centers for Disease Control and Prevention?
So it's interesting, there's differences amongst the guidelines. So the CDC guidelines say that an N95 is preferred, but then they say it's acceptable if there is a shortage. And I think the problem there is you are conflating two different issues. If it is preferred based on the science, it is preferred. Now, if they're not enough and you have to ration them, then one has to admit that you are rationing something useful. So I think the CDC guidelines are a bit problematic when they say an N95 is preferred, but it is acceptable to use an N95 when there is insufficient supply. I think that's where the problem is on the CDC guidelines. When you look at the Surviving Sepsis campaign guidelines, they actually explicitly say that face masks are preferred to N95 based on the evidence. And that, I think, in particular, is not at all supported by a careful look at the evidence and by their own footnotes and references.
Do you think the guidelines will be adjusted in light of what you wrote, or what others are writing, or just the idea of having our healthcare workers be as safe as possible?
That is my sincere hope. One of my goals when I was writing this was very specifically for the guidelines to be changed. There is a difference between saying I've proven the N95s are superior versus saying I've unequivocally shown equivalency between N95 and face mask. And I think it is simply based on the evidence. One cannot say that equivalency has been shown. One study is done on outpatients, so that's not a reasonable extrapolation. That's the Radinovich study. You look at the Loeb study. In that study, the people wore the N95s only when they walked into the room. They were not wearing it continuously like we do today. So to say from those two studies that did not show a benefit and extrapolate to inpatient COVID care when you're wearing it a continuous is just an extrapolation without evidence behind it. So you have those two studies which are a bit more towards the negative side. When you look at the two randomized controlled trials by McIntyre done in China, those actually showed a benefit when you looked at clinical respiratory illness. So very much the hope is that the guidelines will be changed. They're continuously updated. People do the best they can, and I'm hoping that they will be updated.
Again, I'm paraphrasing from the article that you wrote, and tell me if I'm wrong here, but I think you made the point that this allowing surgical masks and medical masks to be used in circumstances where N95s should really be used takes the effort away from having a good supply of N95 masks. Did you not make that point?
I think you hit the nail on the head, and that is the fundamental problem. As long as the guideline writers in society say that they are equivalent, you're not going to have the focused effort to make the N95s. I think once that we as a society admit that there is reasonable evidence to show that N95s are better, my hope is that we will produce them. One has to remember that before this all started, the cost of an N95 mask was about $1. And 3M, right, has made a point that they've actually jacked the prices up. You may not be able to get a 3M N95, but they've not jacked the price up. Remember, it's a piece of plastic and it's made from oil, and a crude barrel of oil is relatively cheap. So I think exactly as you said it, that if we admit that there is reasonable evidence that N95s are better than face masks for inpatient care, instead of us fighting over the supply, we will increase the supply.
Have you gotten much feedback from people? Have you heard from a lot from fellow healthcare professionals, from fellow doctors and nurses?
Well, I've gotten a little feedback. I mean, I've sort of been getting feedback over the past, month or two, on this when we, again, all well-intentioned with the system. And so I got one comment already on the article. They made the point that although we showed a benefit for the N95, the confidence interval did cross 1. The comment was correct, so we actually did give them several other examples where there was benefit to N95 and the confidence interval completely favored that. Certainly some feedback that you've not definitively proved the point. And again, one can criticize the randomized controlled trials, but the question is, right, if you want to be somewhat a precautionary principle, right, how certain do I have to be? I don't think I have to be 99% sure. And the question is, what is the magnitude of benefit, right? If you look at the Radinovich outpatient study, they felt that, if I got the flu, it probably wasn't that big a deal. So unless I reduce the incidence by 20, 25%, not a big deal. Well, that may be true if your case fatality rate is 0.1%, right? If your case fatality rate is 1%, then that same risk of infection becomes much greater. So I think it's making sure people get the extrapolation that we know that this is more infectious than H1N1, that the case fatality rate is certainly higher than regular seasonal flu. We can argue the magnitude. So I do get pushback somewhat on the interpretation, but I think it's important that we separate the interpretation from the facts.
And we had to postpone our interview twice because you're in Fullerton, California, and you're in the midst of a surge right now, right? Dealing with
Correct.
COVID-19. And what, do you have enough N95s where you're working?
So thank goodness we do have enough PPE. We do have enough N95s. You know, one sometimes has the problem that, you know, what you have is not necessarily what people are fitted for. But overall, thank goodness we've been doing okay with that. Difficult.
Have other studies come out since your article that backs up what you said?
So what was interesting is everybody is still fighting over those 4 randomized control trials. So there have been no new randomized control trials. Loeb, who's one of the authors, is actually planning on doing a randomized control trial. I'm not sure where they are, you know, with that. Sort of that came out before we published this. You know, there was the Lancet article that got a lot of press about, you know, the possibility of aerosols and N95s being better. Again, that was critiqued as being observational studies rather than randomized controlled trials. But again, one has to do the best they can. There was another article that sort of did a more detailed review than we did of these 4 randomized controlled trials and sort of came to the same conclusion, that there is evidence that N95s are better by some criteria, not by other criteria. And, you know, what do you do in that situation? You know, the analogy I make to people right now is, for instance, we're using, you know, we're doing TOSI, right, to treat the so-called cytokine storm. That costs several $1,000s a pop. People are doing randomized controlled trials, but we're not so worried about spending the money on that. But again, as society, we're not, you know, allocating the resources for the PPE and the N95.
A lot of my readership are infection preventionists, also hospital administrators, environmental service teams. Any advice for those group of healthcare workers regarding what you wrote and masks in general?
I think it's a very tough position for them to be in. And in my article, I actually commented on that because I think the term moral distress can often be thrown around too loosely, but I think these people have serious moral distress, and it doesn't do society or anybody good for frontline healthcare workers to beat up on these people, right? These people got a supply chain. They have guidelines that say we have to keep them for the aerosol generating procedures, even if the risk is much less, right? Those are the guidelines. You can't fault administrative people for following the guidelines. So I think they're put in a tough spot. But I do think from the administrator point of view, you have to look at the other side. If you look carefully at the evidence, you cannot fairly extrapolate from some of the outpatient study to an inpatient study. I think when healthcare workers uniformly say, we're on the front line, this is what we think we need, and they have evidence to support that, I think the plan has to be that we will supply N95s for you, understanding that there's been evolution of the guidelines. And the other thing I should mention, since we started this paper, you know, we started this in April, you know, it takes a while before it comes out, is the American College of Physicians has very specifically endorsed N95 for COVID care, defined as being within 6 feet of the patient. So again, we all know guidelines are in flux and the evidence is in flux, but I think for administrators and the infection control people, I think the attitude has to be there is enough evidence that N95 is beneficial. The claim that we're going to wait for perfect evidence is just not tenable. We don't do that for anything else in medicine. And the goal has to be, how are we going to get the N95s in sufficient quantity, not if.
And even N95s aren't perfect protection, right? The 95 stands for that it blocks 95% of the pathogen, right? Because there's still 5% possibility of something.
Everything is mitigation, right? Nothing we do is going to be perfect. And I think people have to remember that. We're mitigating risk. We are not eliminating risk.
Doctor, anything you want to add about masks and your article?
No, I think that's it.
Okay. Dr. Harry Peled, thank you so much for joining us here in Infection Control today. And good luck and stay safe. I know you're very busy there.
Thank you so much.